short spine cord on? Probably don't. Do we use mass trousers anymore? Not really, right? So it's constantly changing, okay? So staying up to date in and of itself, you know, the literature is constantly changing. Really from reliable med information, and really you want to, you know, what we have here with your textbook, I mean, let's all face it, that's probably becoming an outdated thing. By the time a textbook comes out, it's probably 2 to 3 years old, in fairness. So, you know, educational stuff, institutions, you know, I work in one of those, you're in one right now. Industry organizations, so, you know, Society of Emergency Medicine, those kinds of things. So, internet software. Let's talk for just a second about this. When my son was in high school, in the library, there was a quote on the wall in the library attributed to Abraham Lincoln. And it said, "Don't believe everything you read on the internet." Okay? Let that sink in for just a second. And so the thing there is you want to use evidence-based resources, right? And so if this is actually listed in your text, I will tell you probably of these now, you know, Lexicomp is one I use, and they do have an app, and I'll write a couple of these down for you here in just a minute. But it is evidence-based, it's constantly updated. Now, drug package inserts and physician's desk reference, I will tell you this slide's a little bit outdated. For all intents and purposes, the package insert is what the FDA requires drug companies to have. It's the prescribing, the chemical component, it's just got lots of required information. The PDF, or excuse me, the physician's desk reference, little spoiler alert, it's nothing but package inserts. And drug companies pay to have them put in there. So it's not gonna have a lot of generic stuff. And the information in a package insert doesn't necessarily mimic what evidence-based things are. And a case in point, and this wouldn't be in the PDR anymore, but years ago when amitriptyline Elavil was a trade name drug and it was one of the few antidepressants we had, well, that's the overdoses you saw more of. And so when you had that, some of the information on how they told you to treat a TCA overdose was very outdated, but that was what the FDA, so the FDA required them to have in there. So my point is, not bashing these two here, but I would lean more towards updated. You want evidence-based guidelines for resources. The two of them, and I've got this written down. I wrote it down somewhere while I was drinking coffee at Panera, but I obviously didn't write it down on that piece of paper. One of them that's on here is Lexicomp, and that's on this slide. The other one, look at my own phone here for just a second, because I have these on my phone. I don't use this one as much because I usually take more of adults. Every once in a while on my weekends, I do take care of kids, and so I do like this. But PDStat, by the way, I'm not quote unquote endorsing these, and I don't get money from these, anything like that. The thing, Lexicomp, the thing I like about it, and you can, and I think a subscription to it may run, I mean, I don't know, it's like 10, maybe 10 or 15 a month total. I mean, if you took, and that sounds like, that's kind of expensive for an app, but it's constantly updated. And it's also got like calculators in it, so it's got the ACLS guidelines, algorithms, it's got pediatric dosing, neonatal dosing, adverse effects, all that identification. You're on the scene and you know, you open up the bag and you're like, holy crap, what am I dealing with here, right? Well, you can identify stuff off of it, so it's kind of helpful. And then PDStat, I really love this. Again, I don't take care of kids, all right? But PDStat is basically by age, weight, height, and it's also basically got a Broslow, electronic Broslow. And you put in, if you're like, hey, ma'am, how old are your kids? You've got a pediatric seizure patient. You're like, how old? Oh, they're 2 years old. Okay. You know, boom. Or how much they weigh? Oh, they weigh this. You put it in there, just like the Broslow, but you just, boom, here's the weight. Oh, here's the neuro, here's the meds, here's the vitals. I used it the other day. My granddaughter had a fever like 104, and my daughter texted, and she's like, hey, the pediatrician thought she had like walking pneumonia. He said, what's the heart rate for a 2-year-old? I was like, heck, I don't know. So I pulled up my PDStat, and I was like, oh, well, of course it's 100, 140, right? So she didn't know I looked it up. But the apps, the whole point of these is obviously you want them to be evidence-based. And don't, by the way, using an app, looking at a reference, looking at a protocol, looking at an algorithm, you're not selling anybody short. To me, I would much rather see somebody look something up than to guess at it. Okay? I use mine every day when I'm on rounds with even, like medical things. A lot of times if they're asking me a question they don't know, well, chances are I may not know either. I may know just sheer experience because I've been there since the dinosaurs. But these apps definitely are beneficial. Okay, so information. So this has become increasingly a big one, is how we select the meds we have. Okay, that first one, availability of medications. I can tell you, I've been in practice at UT. This is my 34th year there. I have never seen anything about like the drug shortages we have had just in the last, say, 5 years or so. COVID certainly affected part of it. The last two hurricanes, when Hurricane Maria hit back, I think it was 2017, somewhere in there, and it was hard to get saline and all this, there were 64 pharmaceutical plants in Puerto Rico. Who knew, right? Okay, well, let's move them to North Carolina. Who would think a freaking right? Who would think a hurricane would come up through the middle part of North Carolina, right? So right now, IV fluids are hard to get. IV potassium is really hard to get, that kind of stuff. The one we were dealing with when I taught back in the spring was you couldn't get vecuronium in certain sizes, okay? And so the reason I say that, and the reason I'm taking a couple minutes to talk about that is, what's on your truck today may be different than what was on there yesterday. So always look at what's that dosage for, okay? Obviously, the things about what we select, is it in the scope of practice? Can I monitor what I'm given? And then, the clinical status. Fancy stuff can't be superseded until we do the basic stuff. So good old BLS, it is always going to be important. So even though we can do all the fancy ACLS stuff, we can't forget the basics. Okay, so other factors that are going to be related to med selection. Years ago, when they taught ACLS, before it became the kinder, gentler ACLS, this is kind of how they would approach this. So we look at, they would call it the what, when, watch out kind of effect, okay? Some of y'all may remember that approach. So indications is just, what am I going to give it for? When am I going to give a drug? That's all that means. Contraindication, watch out. Do I need to be careful about giving this drug in this type of patient? A beta blocker, certain kinds of beta blockers, maybe in an asthmatic. Obviously, do they have allergies? And what is the allergy? What's the nature of it? Pharmacodynamics, this is basically the effect of the drug on the body. Okay, what's the drug going to do to the body? Pharmacokinetics is kind of what's the body going to do to the drug. And we're going to spend several minutes talking about pharmacokinetics in a few minutes, because to me, that's one of the big underpinnings as we talk about critical care. And then the watch out. What do I need to look out for? Potential adverse effects. Most of the time, not always, most of the time, the adverse effects are kind of an extension of its pharmacology. If I give a beta blocker, is it going to shock me if somebody gets bradycardic or hypotensive? Not really, right? And so those are the kinds of things that we'll at least consider. And remember, this first section that we're going through is really more the concept about how is that critical care patient different, and what do I need to understand about that critically ill patient that's going to affect my drug selection and its disposition, okay? So, as we get into pharmacokinetics, again, what does the drug do to the body, okay? Or excuse me, what does the body do to the drug? So we think in terms with, when kind of big picture with kinetics, we think of what's called ADME. And we're going to go through each of these, okay? So absorption, and I am sorry about my penmanship. My daughter got accused of forging a note when she was in middle school for an absence, and I had actually written a note. this may be either elimination or excretion. And we'll come back to these as we go through. So the ADME is kinetics. Now, these all happen concurrently. It's not like I absorb everything, and then I start to distribute it, and then I start to metabolize it, and then I start to eliminate it. This stuff is happening. As soon as it's starting in the body, it's probably doing all the above, okay? So when I think about absorption, I have to think through, so if I take an oral tablet, goes in my stomach, it's got to be dissolved, it's got to be kind of, well, first it's got to break apart, it's got to dissolve, it's got to go into solution, and then it starts to be absorbed. So it's not immediate, right? So when we think about all the different routes, we need to think about, well, how quickly is it going to be absorbed, and how much is it going to be absorbed? And we think in terms of that of bioavailability. That's how much of that drug reaches the systemic circulation, okay? That's bioavailability. How much of the drug reaches the systemic circulation? So this is where, and this is one of the biggies when I think about a critically ill patient. So if I have an IV line, whether central or peripheral, by definition, I should have 100% bioavailability, right? IV or a central line. So then, what about IM? Well, is the person hypotensive? They may not perfuse their skeletal muscle as much, and there may be a delay in the absorption. Kind of makes sense, right? Intranasal. I love me some intranasal, okay? And increasingly, we're using more and more and more intranasal. Well, that's probably pretty good, but what if they have facial trauma? Maybe not, okay? And part of it does depend on the drug. It's highly vascularized, and so actually it's going to be a little delayed. But if you've got the 2-year-old that is all over the place, and it's like trying to do a pin, you're not going to be able to get an IV line, then intranasal works wonderfully. I have been a huge advocate for years, and this is, it's all everywhere, intranasal Narcan. It works slowly, but if this is a patient who suffers from drug addiction, the likelihood of a patient having hepatitis C that has drug addiction is very high if they do intravenous drugs. And so for everybody in the room to not necessarily risk getting stuck. Now, does that mean you're not going to have to start an IV? No, it doesn't mean that at all. But for the immediate problem you've got, supporting their airway and getting some Narcan on board, you've not had to touch a needle yet. Okay, so just stuff like that. So intranasal, subcutaneous, again, now we have to work with subcutaneous access a lot, and I mentioned I work with palliative care some, so we have patients who are at end of life that are comfort care, and maybe they have no longer IV access, and so sometimes we're having to use the sub-Q space with even certain drips and certain meds, but we're limited by volume. We can only put about 3 milliliters an hour into that total sub-Q space of one drug. Now, we may have to use multiple injections or sites, but that's one that you kind of think about. Intraosseous, okay? Again, great access, should get good penetration. Sublingual, a good option unless, and again, I keep using my palliative care patients, or maybe you have an older patient that's on a lot of anticholinergics and they have dry mucous membranes. If I give a sublingual nitro to a patient whose membranes are bone dry, they may not absorb it, okay? And then finally, rectal. We were talking about rectal Valium a few minutes ago. Well, it's erratically absorbed. There's 3 main veins, hemorrhoidal veins, the superior, inferior, and medial. I think it's the superior, 2 of them, I think it's superior and medial bypass first pass effect. I may have that wrong. No, inferior and medial. And so there is, the rectal is an option, but it's kind of variably absorbed. But it may be an option. So all those, so absorption, you might have go, wow, I didn't know there was that much about absorption. And so absorption has everything to do about route, but I need to know what's different about that patient. Again, the one that always pops in my mind is they're hypoperfusing, and I'm giving IM. What's going to be delayed? Okay, or if they don't have a lot of muscle mass. Okay, All right, distribution, highly variable. Some of the examples we think about would be like blood-brain barriers, placental barriers, even within the blood, albumin. So is something bound to protein? Is it not bound to protein? I already kind of mentioned first pass from rectal, but oral medications, a lot of them go through the liver, and we'll come back to the liver in just a second. But you know, is stuff going to be kind of torn up there? So two things here. So distribution, here's an example for you where that makes a difference. So somebody's having a seizure, and I've got lorazepam, Rativan, and I've got diazepam or Valium, okay? Are both of those drugs acceptable to use for a seizure? Absolutely, okay? Is there any potential advantage of one over the other? Okay?
Diazepam has a longer half-life.
Okay? Potentially. And so actually, no, and that's a good point. It does. So here's a couple of little things. So from a practicality standpoint, diazepam is more stable at room temperature. I can have lorazepam out of the fridge for about 28 days. So, you know, unless, I know some of the newer modules in some of the medic units may actually have a fridge. So in addition to keeping your sandwich cold, not kidding, no, but that would be nice because it extends your drugs. Okay, now, so you're right, Valium has longer half-life because of metabolites. I'm jumping ahead a little bit, but here's one of the, it used to be diazepam used to be drug of choice. The reason we use a lot more lorazepam in the hospital is that, so Valium, let me think, I think I can explain this without drawing it because I draw worse than I write. So Valium has, its distribution is very wide. It gets access across the central nervous system very quickly. So it gets in there real quick, but because it has a wide volume of distribution, the levels in the central nervous system drop off a little quicker, and therefore it is very long half-life in your system. Lorazepam is a little slower entrance into the central nervous system, but not clinically significant, but it tends to maintain levels in the central nervous system because it's not as widely distributed. Does that make sense? So again, both of them are perfectly acceptable, but that might be why your Valium, and it might be, man, they're breaking through the Valium. Well, it may not that they're breaking through, it's just that your central nervous system level has dropped off. Okay? So that's really all that does. So that's one example. The other thing is, if something is highly protein bound, maybe they're malnourished, then it may not reach its site of action. Okay, or more may be available. If we've got a patient that's malnourished, or maybe they're a dialysis patient and they have low albumin, they may get toxic quicker on something like Dilantin because there's more free drug that's not available to bind to albumin because there's not as much albumin. Okay, so that's one example of that. Okay, biotransformation. This does occur at other sites, but for all intents and purposes, the liver is your primary place that breaks things down. And there's probably more than this, but I think the 4 examples they give in your text is one of the things the liver can do is break things down into inactive metabolites to get rid of it. The other one is it'll change it to an active metabolite. So back to diazepam. Diazepam breaks down into and you don't need to remember this, just an example. Desmethyldiazepam, which is an active metabolite, has a half-life of like 90 to 100 hours. I mean, it's long, okay? A prodrug that might convert it into an active form, an example of that is like Plavix or clopidogrel. It has to be activated into its main form. And then a prodrug that might become a toxic metabolite. And that might be something, even though it's an intermediate, we'll come back to this, but it's like Tylenol, okay? So then we get into elimination. So that's biotransformation. Just to understand that obviously we have to get it out of the body somehow, so it has to be broken down, or it may even have to be converted. Elimination, there's 2 main forms of elimination. I'll give you a couple examples. So the first one is called zero order, okay? With zero order, you have a fixed amount of the drug that's broken down per unit of time. Best example of that's alcohol. Let's say I have a blood alcohol level of 300, and I clear, and this I'm making these numbers up, okay? And I clear 10 milligrams per deciliter per hour. So that means in an hour, I'm gonna be at 290, in another hour, I'm gonna be at 280, and so on and so on and so on, okay? Versus first order elimination is a percentage of time every unit of time. So example of that would be like heparin. Well, every 90 minutes, heparin breaks down by 50%, okay? And so when I'm in the hospital, if you see somebody on a heparin drip and we're measuring what's called a PTT, a prothromboplastin time, so PTT, that's what we measure to see if anybody's toxic or therapeutic. So let's say for kicks and giggles, I've got a PTT of 80, and I need to turn that drip off to facilitate a procedure. Well, if my PTT is 80 and my half-life is roughly 90 minutes, in an hour and a half it'll be 40, and in another hour and a half it's going to be off, because my baseline is usually 25 seconds, okay? So zero order, amount per time, first order, percentage per time. So, and give you kind of an idea, and we'll come back to this in a few minutes and talk about half-lives. But heparin is minutes, about 90 minutes. Adenosine, think about adenosine, 9 seconds, right? Push flush, right? Push flush, it's like 9 seconds. Amiodarone's weeks. Its half-life's weeks. That's why we have to put them on drips. We have to load them, and even once you stop it, it's on board for quite a while, okay? All right. I know it's, again, a lot of this is nebulous, so we kind of bear with me, but this will lead us to the drug therapy talk when we hear it in a while. All right. This is really probably more of the nebulous stuff, but it kind of gives background. So, some of the theories of how the different drugs work. One of them is they bind with a specific receptor, and they either cause an effect or inhibit an effect. Good examples of that are stuff like atropine, like blocks the vagus nerve, okay? Benadryl blocks the histamine receptor, okay? The other thing is it might affect certain physiologic properties, and probably two examples of this, and more we're seeing, things like anti-rejection drugs or immunotherapies, from everything from psoriasis to rheumatoid arthritis, Crohn's disease, where we're literally blocking a physiologic part of the system. We might combine with other body chemicals to either, again, cause or limit an effect. Probably an example of this one would be when we treat a Tylenol overdose. We give N-acetylcysteine, which mucum is, which you're going, wait, I thought that was a nebulized thing. It is. It's a mucolytic, but it also restores a pathway, and again, not important you know the pathway, but glutathione. So when you take Tylenol, real quick, you take Tylenol, it breaks down into metabolites. One of them is kind of a toxic metabolite, but your system usually uses glutathione to quickly break it down and it goes out the body. No harm, no foul. But it's dependent on an amount. So if I take a toxic amount of Tylenol, it converts it, I overwhelm and deplete my glutathione real quick, and then that metabolite that usually is gone quickly is not, and that's what torches your liver, okay? So does Tylenol do it? Not really, it's a metabolite, but it was the root cause. And so that when we give N-acetylcysteine drips, we're restoring that metabolic pathway so that it's clear, okay? So that's an example of that one. And then the last example here is where we can actually affect a metabolic pathway to affect something. Again, another overdose example here, if somebody ingests ethylene glycol or methanol, we'll actually use a drug called fomepizole. And we used to use ethanol. It basically competes with like ethylene glycol for this enzyme called alcohol dehydrogenase. And so you're competing so that the methanol or the ethylene glycol are not converted to their toxic components, and then they just clear them out. We literally, before fomepizole came out, which is an injection, we literally would hang an alcohol drip, and we would we'd basically get them legally crocked, and that's how we would treat them. Vets still, if a dog gets into antifreeze, they might immediately tell them to pour a bunch of beer in a thing and let the dog sit there and lap it up to hopefully try to mitigate them not going into renal failure, okay? because the alcohol competes for it. I'm not a veterinarian, but that's one of the things they at least used to do, okay? Now, building on what we just talked about, and this is probably the more familiar terminology, an agonist, when we hit a receptor and we cause an effect, it's an agonist, okay? Some of the ones we'll talk about in a little while, and again, critical care kind of 101. Stuff like vasopressors, we were talking about this before class. Vasopressors, alpha-1, it's going to stimulate it and cause an effect. Albuterol, it's an agonist. When we stimulate that beta-2 receptor, it causes an effect, and we'll come back to those here shortly. We block an effect. Okay, I already mentioned atropine, so an antagonist, if I hit that anticholinergic pathway, I block the effect of the vagus nerve and therefore increase my heart rate, right? That's what our atropine does. And of course, naloxone, we block the opiate receptor. Those are antagonists, okay? So there's also, not to confuse things, but you may see sometimes listed things like agonist, antagonist, and you're like, what? They have partial effects, so probably the best example, that's buprenorphine, which is one of the components of like Suboxone, and so, or Subutex. So it can actually be used very effectively to help people that have an addiction to opiates, but it'll have an agonist effect like on one of the thing called the mu receptor and an antagonist on what's called kappa receptor. And so it should hopefully help prevent respiratory depression by doing that. But there is a catch-22. We deal with this a lot of times. So if somebody's already on like buprenorphine, and then they come in and we're having to give them opiates, and we'll come back to this in a few minutes, but it can have an additive effect. But if somebody is, let's say they are, they use fentanyl, heroin, or whatever, and then we give them buprenorphine, or maybe they're already on oxycodone, it can actually cause withdrawal, okay? I saw an article, I didn't get a chance to read it yesterday. I want to say it was either Portland or Seattle. Their medics are starting to use buprenorphine in some of their opiate overdoses. That was in Jim's, if you read some of their stuff. I literally just have Jim's table of contents sent to my email every day. That way you can key in. That's a good way to keep up with some stuff. And they have some free CE on there, so if you haven't tapped into that. All right, drug response relationship. When we're giving an agent, we want to not just know what's it supposed to do, again, kind of how long is it going to last, what should I expect, but I kind of want to know when am I expecting it to kick in, right? So, and how long is it going to last? So that has a lot to do with half-life, okay? And so basically the time it takes to reach the effective level is onset of action. Again, adenosine, pretty darn quick, right? We see that obviously used a lot. I remember working with a medic who used to work at my station. I ran a call, and this lady, man, she was just tacking along, and he basically said, "Hey, you're getting ready to feel really bad." And I was the first time I heard somebody say that, and I thought, well, that's kind of not good. But then it made a lot of sense. He goes, we're going to know it's working if you feel bad, but don't worry, it's going to be real quick. Well, he gave it, she felt bad, and she got better, okay? I was actually a resident when adenosine came on the market, and we actually had a patient that was in PSVT. I mean, he was fairly stable, but it was the first time really anybody on that floor. This is when I was in North Carolina. We went in the room, and this is still kind of surreal because I remember this now 35-something years later. So of course, what is one of the very transient side effects of adenosine? What can you get on the monitor? Yeah, asystole, right? But it doesn't last long. By the time you have to treat it, it's gone. Well, again, bear in mind, this is when drug first came out. So this guy, he was like dialysis patient. And again, in my mind, this is frozen for some reason. The dude's watching like the Cubs play on WGN, okay? And there was no such thing as DirecTV or anything. You had cable, okay? So he's watching the Cubs. They give it to him, and he takes his little 7th inning stretch of asystole, right? And then we're all like,